Hello, and welcome to Scholars Hub at Home. I'm Rose Luchavello, Manager of Advancement Events. Thank you for joining us for today's session. Is race a social determinant of health? Before we get started, I would like to take a moment to acknowledge the land I am on. Because we may not be gathered in the same place, the land I'm about to acknowledge might not be for the territory you are on. Please take the responsibility to acknowledge the traditional territory you are on. As a member of the York University community, I recognize that many Indigenous nations have longstanding relationships with the territories upon which York University's campuses are located that precede the establishment of York University. York University acknowledges its presence on the traditional territory of many Indigenous nations. The area known as Takaranto has been caretaken by the Anishinaabeg Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. This territory is subject of the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. Now, we would like to conduct a quick poll before the session begins. The question is, how would you rate your knowledge regarding the topic of today's presentation? The poll should pop up on your screen right now. We'll give you a moment to fill it out. Great. Okay, great. Thank you, and it's helpful for us to know for the perspective from our audience. If you need help with Zoom webinar, please feel free to click on the Q&A button at the bottom of your screen and enter your question. Our team is ready to help you. The same button may be used to submit questions for our guest speaker during the Q&A period. Please note that all of your questions and comments are visible to the panelists and staff working behind the scenes, so we ask that you please keep your comments relevant and respectful. Now, I would like to introduce our host for this afternoon, Dr. Sashil Singh. Dr. Singh is an assistant professor in the School of Kinesiology and Health Science in the Faculty of Health. His work is interdisciplinary with a focus on medical sociology, racial discrimination, and bias in healthcare. Welcome, Dr. Sashil Singh.
Thank you so much, Rose. I appreciate the introduction. Thank you to you and your team for putting this all together. I really appreciate that. And thank you to the attendees. Thank you for taking the time out of your busy schedule to join me today. I'm going to go ahead and share my screen. Okay, so today's talk is a social determinant of health, is a common question that comes up when studying the sociology of health, when examining health policy and so on. But it's a question that I think about very often because as a sociologist, there are a number of aspects to this that I think demand a closer interrogation. So today, we want to look at whether race is a social determinant of health, if this is important, if it is not a social determinant of health, then are there perhaps other social determinants of health that a race stands in for? Now, the dominant view is that it is a social determinant of health. But as I say, as a sociologist, I'm here to examine what exactly this means, this framing, and if it matters. So there are three main things that I want to do today. The first is to explore what exactly we mean by a social determinant of health. We'll then examine some examples to provide context. And then we want to look at whether race is used as a proxy for other social factors. So social determinants of health are aspects of the social world that influence health outcomes. They are non-medical factors that encompass the conditions in which people are born, grow, live, uh, age, and so on. They include economic policies, social norms, and political systems. Now, in this diagram that I have for you, Sterling et al. Highlight a number of the social determinants of health, and in black text, they draw attention to some of the greatest contributors. So for Sterling et al., these aspects in black text are those that are most prone to suffering the greatest when it comes to social determinants of health. The benefit of research in the field is that it brings attention to the racialized populations that are most affected in the health system. So for example, Atkins talks about health conditions and health risks and tells us that the inequalities that are examined in their piece have a distinct racial cast. So very clearly telling us that there is a racial topography to health conditions. Similarly, Aladdin et al. In their 2021 piece examined the relationship between race and post-operative complications following surgery. A Toronto-based CEO of a think tank, Dr. Kwame Mackenzie, argues that race data promotes good medicine. In other words, if we forego the collection of this data, then we are doing a disservice to our populations. So the benefit of the research in this field is that it brings attention to racial inequality in the medical system. But as I argue, it actually uses the race as a proxy for other social factors. Even in France, where the collection of race data is unconstitutional, calls for the documentation of the racial contours of the disease were ignited by groups such as the National Institute for Demographic Studies. Now, let's look at some examples. During the pandemic, there was a lot of debate on whether race was an important piece of data or not. Many policymakers were reluctant to embrace the idea because they said that the virus does not discriminate. At the same time, though, many social justice advocates argued that the impacts of COVID had disproportionate impacts on populations. And as a result of this, they said, of course, this data is key. But it seems to me that both arguments fail to consider key points, such as COVID-19 clearly discriminated against social circumstances. That's a shortcoming of the policymakers, I would argue. And then when we look at the social justice advocates, what they don't consider is how we should go about with the measurement of a race. Do we ask patients to self-identify? If that's the case, one patient's definition of a race could be different to the next patient. An alternative is that we ask a nurse who does the intake to decide on the race of the patient based on their visual appearance. Both have their problems and concerns. Now, in May 2020, the single largest outbreak of COVID in North America occurred at the Cargill meat processing plant in Alberta. The first case was confirmed on April 6th of the year, but by then, nearly half of the workforce, that was about 950 staff, tested positive just 1 month later. This also then contributed to the spread of the virus amongst hundreds of family members. Investigative journalists exposed the working conditions at Cargill. The main issues that they uncovered were the employees were forced to work elbow to elbow. They used change rooms with insufficient physical distancing. Employers expected asymptomatic employees to be back on the floor even while they awaited test results for COVID tests, and so on. So against this backdrop, anti-discrimination advocates called for the collection of race data to understand how COVID-19 was impacting Filipinos in Canada. Again, this was sparked by the fact that most employees at this processing plant were Filipino. This is the important piece. Yes, many Filipinos were infected, and this fueled calls for the data to be to include the a racial aspect. But the important point is that not all Filipinos work at meat processing plants, right? So if you collect the race data to understand how Filipinos are affected, then you make a number of assumptions about the places where Filipinos are employed. So what we can take from that example is that a race is not static or even all-encompassing for a demographic group. Another example, consider a Black patient seeking care at the Royal Melbourne Hospital in Australia in 2025, and then a Black patient seeking care at the New Somerset Hospital in Cape Town, South Africa in 1960. While the race of the patients might be the same by some arbitrary standard, the societal valuations and differences in context of each example are what provide meaning to the race in the respective cases. Put differently, if we say that a race is a social determinant of health, then Blackness alone should determine similar patient outcomes, irrespective of time or space. Additionally, time, space, social structure, and health policy, and even cultural perceptions distinguish the two contexts of Australia and South Africa in this example that I've got for you. And they account for different contextual values of race. Now, at the peak of South African apartheid, a Black individual likely would not even have been able to seek care at a whites-only hospital, as the racist principles of the time were upheld by the law, public enforcers, and by a racist public perceptions. By contrast, however, there are no such laws in present-day Australia, which indicates that a race-based treatment in the two cases is not inherently connected. So then we ask the question, is it in fact the case that a race is a social determinant of health? So if race is a social determinant of health, then we might say, if you look at that first block on the screen, there is consistency in the racial experiences within the races in the health system. But do all people in a supposed a, a race group face the same challenges in the health system because of their race? No, they don't. What about the second block that we have here? If we say that a race is a social determinant of health, then people within the race groups that we are talking about engage in the same social activities and or behaviors that make them prone to health conditions. Well, for this point to be true, we would need to engage in, they would have to engage in the same patterns of socialization, employment, and even have the same tastes and preferences. But this also is not always true. What about the third one that we have here? Race is measurable with clear distinctions between race groups. Well, for this to be true, the question I have is, how do we measure race? Is it through self-identification, as I asked earlier on? While self-identification certainly empowers individuals, it does not provide the criteria for consistent measurement to be medically insightful. So perhaps then we talk about the medical measurement of race. Well, I have ominous reminders from a Nazi Germany or apartheid South Africa when that was done. And I don't think that's the road that we want to go down. Rather, what I argue is that race is used as a proxy to explain deeper social problems. And some of those social problems are the ones that I have on the screen now. So in the literature on social determinants of health, these are some of the factors that come up in affecting the health of a patient. It could be their income. For Feng et al., that's the second point here. In the case of the US, it's whether the patient has insurance or not. It's to do with the resources at the hospital. It's to do with barriers to care at hospitals. If a patient has a virus and they take public transportation, well, that might contribute to the spread of the virus over a patient who has a private car and can drive themselves to a hospital. So this brings up, in a number of cases, aspects of social and economic class. What about crowded housing conditions? In certain cultures, there is a tendency towards extended families staying under the same roof. In other cases, it's due to socioeconomic factors that houses could be crowded. But again, more people in a house could lead to the growing spread of a virus. Notably, the social problems on this slide that many authors document are social determinants of health, but they have nothing inherent to do with the racial attributes of a patient. Rather, they are to do with the broader social environments that are often experienced racially. And there's a key difference there. So in considering this topic that I've brought to you today, the first main point I want you to take from it is that a framing of a race as a social determinant of health might actually promote social injustice. That is, despite the intention of it promoting social justice. asserting that race essentializes occupations, behaviors, lifestyles, and choices as race-based. This assertion also denies the temporal fluidity of the racial self-identification of a patient because of the implicit underlying requirement in such an argument that race is measurable and static. Despite noble intentions, reducing a race group to certain characteristics in the interests of healthcare is dangerous both for perpetuating racism and for fueling a social stigma. The second main point I wanted to take is focusing on race as a social determinant of health distracts from broader social causes of health concerns. So instead of a preoccupation with the race of a patient, focus should shift, perhaps in the case of viral infections, to factors such as living in crowded, multi-generational households, people who face barriers to accessing healthcare and social services, those with underlying health conditions, those involved in essential employment, including those involved in food processing, meat packing, healthcare, and so on. Those who live paycheck to paycheck without paid sick time. So they might still have to go to work because they don't get days off. So what I would prefer to see is greater attention to the social contributors to health conditions, as opposed to attention to proxies that may or may not provide the intended insights. Thank you so much, everyone. I will stop there.
That's great. Thank you so much, Dr. Singh, for that talk just now. So for our audience, we now have time for some questions. Please use the Q&A function at the bottom of your screen, and we will have a question and answer right now with Dr. Singh. So our first question that we're going to ask you is, why do you think that the widespread view is to associate race with social determinants of health, in your opinion?
So I think that's the dominant view because firstly, it's a lot cheaper to do so. It's quicker. And there are correlations that can be created between the race of a patient and health outcomes. But I would argue that that is a distraction from broader underlying social problems. And so I think although there is merit to work in that area, there is a risk that it can overlook the fact that a race is a proxy for these broader social problems, I would argue.
Yeah. So we have a question from Danielle, who's in our audience, and she says, I believe your message is that there are cultural and class conditions that help or hurt people who are afflicted or injured, but in reality, only actual genetic differences, such as sickle cell or cystic fibrosis, are actually underlying determinants of health. So if this is so, should we be encouraging genetic testing for all, such as, they've encouraged for newborns in the UK in order to properly diagnose and treat? What would be your response to that?
Sorry, I'm just going through Danielle's question here
Yes,
myself.
if you read the rest, yes. She said it could be supplemented by adding additional support,
Yes.
such as nutrition, rehabilitation after surgery, and for those who are unable to heal properly in their home settings.
So I have colleagues in genetics who identify the benefits of genetic testing to help get to deeper underlying health concerns that affect individuals. The problem, of course, is that that is incredibly expensive. And so that's one of the main factors for why it's not done on a regular basis. We have to be cautious also. If we are to go down the road of genetic testing, we don't want for that to be done or to be seen in line with the racialized experiences of patients, because race is not a medical or objective construct, it's a social one. So it's very important that we keep the race side of things separate from the genetic side of things. I hope that answers the question.
So actually with that though, you talk about race versus racism in healthcare. So
Yes.
is this difference substantive one or just a matter of semantics? And if you can explain that a little more, because I think that kind of links with what you were just saying.
Yeah. So to say that race is a social determinant of health, I would argue is a misnomer. But to say that uh, uh, to say that uh, uh, racism is a social determinant of health, this brings attention to how people are treated in healthcare because of perceptions of their race. And that's a very important distinction to make. It's the perceptions towards the race of a patient that result in certain outcomes. This difference is more than semantics, I would argue. The one is a term for people to self-identify, and the other is about unfair treatment in the health system due to perceptions of a patient.
So I'm going to kind of piggyback onto that question, but something you hear about often are um, like the mortality rates of women giving birth, and that there are certain skews. Like I think you hear in the United States, for example, that Black women have been known to have higher rates of dying in labor, for example, as opposed. So I'm just curious. I thought I would kind of, because you're mentioning the treatment, would that be the factor that you say would potentially lead to an outcome like that? Because that is something that's spoken of on,
Absolutely.
you see it in the news. It's something that kind of comes out every once in a while. So I'll let you kind of, I don't know, I may not be your area, but just would you say that's kind of the determinant of that?
Yeah, so one of the main reasons that we find for why women have those fatal outcomes, such as during labor, is because they are not given the medication that they need. And I'm talking specifically about women who are Black or perceived to be Black.
Yes.
The reason is, and this isn't something from 1822, it's from 2025. The view is that Black patients exaggerate their pain. And as a result of that, don't give them the medication that they need, right? We see the same thing with algorithms that are designed to detect a patient's probability of getting a heart attack, where race is drawn into it. And the view is that just because a patient is Black or perceived to be Black, that they are at a higher risk. And so when we go down such a path, we are focusing on the visual perception of a patient as opposed to the health conditions that might be affecting the individual. Particularly within the last 10 years or so, there is this acceleration in the development of algorithms to be used in the health system. The benefit of algorithms is it's efficient, it reduces costs, and so on. But in order for them to work, you have to put in proxies, and a proxy is race, because there is such a widespread correlation between certain health conditions and the race of a patient. But then what you are effect doing is overlooking patients who fall outside of those population groups who might be suffering from the health condition that you are ironically trying to test for, right?
So I'm curious to know if age ever gets added as a variable within this discussion, because, you imagine elder people experience healthcare system very differently than, maybe with a little different level of urgency or different treated differently, within the healthcare system. So do you think age is ever a variable that even changes the experience for someone who's elderly, for example?
Absolutely. So I touch on age a bit only in the work that I do, but what I have seen is in the clinical tests that are done, which then provide the insights for how to treat a patient. Those clinical tests are often limited to specific patient demographics, i.e., limited to white men in their 30s and 40s. But the outcomes of that are then extrapolated to a broader patient population. So when we talk about age, what happens to a patient of Southeast Indian descent in their 60s who might be experiencing health conditions that are quite different to those who were used in the sample at the outset, right? So in order for these systems to have to maximize the benefit of these systems, we need to be testing on representative population groups and not simply limiting it to to a very small sample.
Another question from Danielle came in. Would you agree that gender also affects the diagnosis, treatment, and outcome, perhaps even more? For example, failure to diagnose heart attacks, overprescription of mood-altering drugs, etc.
Yep, as I just said in my previous answer, clinical trials continue to focus predominantly on white men, and those results are then used for people of other uh, race groups, genders, ages, and so on. And so that's a that's a very big problem. And again, this is not something from the 18th century,
Yeah.
even though it sounds like it is. This stuff happens very much so in the present day.
So a question that's coming from one of our people viewing on Facebook is, what are the negative consequences that we could face as a society or individuals if we continue with this narrative that race is a determinant of health? How, what effect does that have?
Yeah, that's a good question. So the effect is we continue to overlook underlying social causes of health conditions. That's the main one. Social determinants of health are huge factors in influencing patient health. And so that's why my argument is that we need to be looking at those social circumstances that impact a patient. Race is not a social circumstance. It's a form of identification. And so if we continue to focus on race as a social determinant of health, then the risk is going to be to the health of patients.
So what do you think you could be done to kind of change, it, like, if you think for future to turn this into something positive, what do you think, like, what could be done by those who have the power or the ability or the influence, to change things? What would be your recommendations? Dream world,
Uh,
in a dream
yes.
land.
Well, we need more debate. We need more discussion about this. It's very fashionable and very easy to say that uh, a race is a social determinant of health. Even like that's the motto of people who believe in social justice, and it's and I would argue that it's only part of the puzzle. We have to dig deeper. So we need more open discussion. Platforms such as this one allow for that. We need greater education in medical schools, in faculties of health, because the curriculum in the work that I've done in Ontario shows that in a number of medical schools, there is a deficiency in terms of examining what we actually mean by a social determinant of health. There is still a framing that we need to look at the race of a patient instead of digging deeper. So education, discussion, and so on are key, I think, for getting us to a better place.
So one of our viewers is saying, would you say then we need to say racism is a social determinant of health? What do you think of
Yes,
that statement?
correct. It's not only a racism, it's also racial discrimination, it's a racial bias. These are contributing social determinants of health, not race, which is a label.
So I think so we have a couple of questions left. So can you expand your study to examine where in doctors' treatment guidelines or insurance coverage guidelines would expose any hard rules that, that kind of tie the doctor's hands, the medical practitioners?
Yes, so I can give an example. One aspect of my study is on point of care tools. And these are essentially the apps that doctors have on their phones or on a computer, which they use during patient consultation. So a patient comes in and they say, oh, I've got a fever, I have a cough, I've got this symptom and this symptom. And the doctor has an idea of what the problem is, but they want to just confirm. So they go to the app, they type in the symptoms, and the app says, the patient likely has this, or this. The recommendation is for the patient to take A, B, and C, and so on. In that app, it also talks about the racial groups that are most likely to experience each of the diseases or illnesses or whatever that are specified in the app. And the doctors take this at face value. Why? Because these are reputable apps. Dynamed is an example of such an app. Because they are reputable apps and this data is in the app, there is a reproduction of the problem because the doctor then makes their diagnosis based on the information that they receive. So that is one site of where we find the problem being transferred from the doctor setting into the life of a patient.
Very, very interesting. So to close off, actually, I'm going to ask, Julia had asked earlier today if you're on LinkedIn, and I think is interested in following you on LinkedIn. Just want to kind of put that out there if you want to speak to that.
I'm not on,
Okay.
but I would be happy for Julia to search for me on my York profile, and I would be
Great.
happy to keep in touch.
Excellent. So I think with that, we will wrap the questions up for today. Thank you so much. It was so interesting. Oh, and she has just commented that she will.
I see that.
She will start
Great,
seeing.
Julia. Thank you.
Great. So with that, we will wrap up the question and answer. And again, we want to thank you so much for taking the time to be with us today. And, like you said, this is a platform, a small platform, but anything you can do to kind of get this conversation rolling or have people thinking differently is just a starting ground. So thank you so much again for taking part and being with us today.
Thank you so much. I really appreciate the opportunity.
Take
Thank
care.
you. You too.
And for everyone, a recording of this video will be posted on our YouTube channel. Please see the link in our chat. We do have one more poll question for you, and it's how would you rate your knowledge of today's topic following this discussion? Thanks so much. Please join us for our next Scholars Hub on Thursday, 17th, featuring Professor Drake, Research Fellow at the Department of Politics of the Faculty of Liberal Arts and Professional Studies. On Wednesday, April 23rd, Scholars Hub will return with Alicia Lim, an Assistant Professor of the Technological Humanities in the Faculty of Liberal Arts and Professional Studies as well, and we'll be speaking about why we consider digital platforms to be 400 years old, taking us on a trip from the East India Company to Amazon. To register for all of these events and learn more about upcoming sessions, please visit yorku.ca/alumni and friends. Thank you so much and be well.